Okay, it looks like everybody wants loss of consciousness. Okay. Then we'll go ahead and get started with that in about a minute. Okay. All right, so I see a lot of familiar names here. I think a few that haven't been with us before, but basically what we're going to be doing, just for the people who have not done this before, is we're going to go through this case. I don't know, this is a case that I didn't write, so I don't know exactly what the outcome of the case is. And so with that, if I don't know something, and I'm going to not know a lot of things, just keep that in mind, that I'm a resident, so I don't know, I don't have a ton of experience, but I'll try my best. And I want you guys to, as much as you can, to participate and and you can either type in the chat, or you can call out on the Google Meet platform. And then if anybody from YouTube or on TikTok, if anybody has questions, you can type it out, and I'll go ahead and try to answer them. So, and then for the people that are on TikTok, there is a link in my bio that has a link to the actual Google Meet, what's it called? Like meeting, I guess is the right word. And you can go ahead and just join that. Okay, so let's get started. So we have a man who appears to be in his late 50s is brought to the ER. The history is given by EMTs who state they were called to a store for a 50-year-old male who possibly had a stroke. At the store, they found him lying on the ground unconscious but breathing normally. After their arrival, the patient awoke but was unable to give coherent responses or questions to questions or commands. So the guy was found down, and he was breathing normally when he was unconscious, and he was able to be woken up, but he's still a little confused. Store employees saw the patient reported to EMTs that he fell to the ground suddenly from a sitting position, then began drilling, and his arms and legs shook for what seemed to be a long time. But they cannot quantify for how long. They say he had not appeared ill before the event. Okay. Does anybody kind of want to give me kind of their thoughts on the patient's initial presentation? And you can just go ahead and talk if you would like. If not, to make it a bit more interactive, I might call on you guys. So, Kashika, do you want to kind of explain your thinking behind how this patient presents?
Yes. So I was thinking. Oh, am I echoing?
No, you're good. I can fine.
Okay, so I was thinking that maybe it could be a seizure because his arms and legs were shaking and he was drooling. And he wasn't really appearing ill before the event. So usually I've seen seizures being like sudden, but I don't have very much experience studying them. So that's all I have for now.
Yeah, and so it looks like, sudden onset, shaking of the arms and legs, and then the other part of that of this is that he's also confused afterwards. And with a seizure, a lot of times you have what we call a postictal state, where you have the acute seizure, you're shaking, or sometimes you're just out of it. And I had a patient that in the hospital that we didn't really quite know what was going on. She appeared to be altered out of nowhere. And turns out that she was most likely having a seizure because she would just be completely unresponsive and then slowly wake up out of it. And so seizures can present as multiple different things, but yes, this acute onset, the arms and legs shaking, the patient being confused afterwards does definitely sound like a seizure. Is there anything else that this can possibly be? They're saying it was a stroke. Does this sound like a stroke? have a just a side note. I have one of my past co-residents now attendings in this meeting. So if he wants to chime in when I get things wrong, that's okay too. Okay. So I mean, it can possibly be a stroke. When we think of seizure, we don't typically say we don't say, okay, he had a seizure and that's it, right? We have to figure out what's the provoking cause of the seizure. If he was young, you know, he might have other issues going on. I mean, he might have like a congenital abnormality or another reason why he can have a seizure. But in older adults, we got to figure out why. So something like a mass can cause a seizure. A bleed in the brain can cause a seizure as well. Infections can cause seizures, and there's probably more that I'm forgetting. But those are what's coming to mind at this time. Okay, and does everybody know how to access this case? If not, I can try to post it in the comments. Let me see. So that's the link, and then it gives loss of consciousness of a 50-year-old. Okay. Yeah, someone on YouTube saying could be a stroke, but lower on the differential. Okay. All right. So review of systems. Patient is unable to provide any information at this time. I'm assuming he's still confused then. Past medical history unavailable. I guess he's still confused. Okay. So physical exam. So he's awake, saliva and blood at the corner of his mouth. He appears well developed. Appearance is consistent with stated age. Okay, perfect. So vital signs. So does anybody want to interpret the vitals for me? Okay, Mariam, go ahead. So we got the temp of 36.5, pulse is 80, BP is 165 over 90, and respiratory rate is 20.
So the temperature looks normal because it's 97.7 degrees. And then the pulse, I think that's also normal because I think the range is 60 to 100. And then the blood pressure looks a little bit high.
Yeah.
And then the respiration, I don't remember what the range is.
So yeah, up to 20. So it's kind of on the higher side of normal.
Okay.
Yeah. So the BP is the only one that's like starkly abnormal. The blood pressure 165 over 90. We don't know his past medical history. And so possibly, I mean, if he has a history of hypertension, possibly this is his normal, but we don't know that. With strokes, sometimes, because the EMT said he had a stroke or had stroke-like symptoms. When we have an elevated blood pressure, that's part of your body's physiologic response to try to increase perfusion up to the brain, right? So your blood pressure is going to be increased a little bit to try to get more blood flow to that area that was cut off of blood. So that can be a potential sign of a stroke as well. We don't quite know yet, and we will see at the physical exam if he has any signs or symptoms of a stroke. So, all right. So skin is pink, warm, and dry. Few punctate red spots on the right lower leg. Okay. Does anybody know what that might be indicative of? Punctate red spots in the right lower leg. I'm assuming, Kashika, that it's probably not relevant. That's why they don't have the O2 sat. Cellulitis would be more of kind of a area of redness, not just like little small dots of red. Dr. Mansana, do you know? Are you thinking what I'm thinking?
Hey, Dr. Nakfi, sorry, I've got a screaming baby syndrome right now at home.
Oh, okay. Okay, no, go
I'll
for
try
it.
to end
It's
it.
okay.
But I'm so proud of you, everyone. Dr. Nakfi's the best. He's so awesome.
Thanks, Carlo. Okay, so yeah, so somebody on YouTube is saying thrombocytopenia, which what I'm thinking of is maybe there's some reason why his platelet count is super low that's causing him to have small bleeds somewhere, and the thought behind it is that your platelets help cover up these small bleeds. So like if you have a bleed somewhere, your platelets will go and attach and clot that off right away, so you're not having profuse bleeding. But when you have these little pinpoint, what we call petechiae, it's a lot of times it's because your platelets are low, or you can have just damage to the upper levels of the skin that can cause it. I sometimes, whenever I put like a backpack on or if I exercise, I get petechiae kind of up here in my chest, and it's not indicative of anything per se, but it makes you think the platelet count might be low. So Dr. Yasmin's asking, how do we know that the platelet is low? It's because these punctate red spots in the right lower leg, one, we don't really know what that is. I'm just trying to figure out why this patient has had a potential seizure. The reason why I'm thinking is because they're bringing up these red spots, and if these are petechiae, these small, let me see if I can, I probably won't be able to show you the screen. They're these small little dots, and if you Google petechiae, you'll probably be able to see it, that occur because your platelet counts are, a lot of times they occur because your platelet counts are low, because a platelet would stop those small little tiny bleeds from happening. And if you don't have enough platelets and you're seeing that on your skin, that can potentially be a sign of low platelets. Does that answer your question? Okay, cool. So one possibility. So there's no evidence of scalp trauma. Hepatic membranes are clear. There's a puncture wound on the bottom of his tongue, so I guess he just bit his tongue. Hint exam is otherwise unremarkable. No respiratory distress. Equal breath sounds bilaterally with good entry. No wheezing. Okay, so his lungs are clear. CV looks normal. Okay. GI is unremarkable. GU is unremarkable except he peed himself. And then full range of motion in the extremities. No deformities, tenderness, or bruises. Okay. Does somebody want to go through the neurologic exam with me? And I'll start reading it, and if anybody wants to, just comment. So the pupils are equal and normally reactive to light, known as stagmus. Face is symmetric, gag reflex present and symmetric. Can move all limbs equally to command, but does not comprehend commands for more detailed motor function testing. Okay. Deep tendon reflexes are symmetric and 2+ throughout. Plantar reflexes are downgoing bilaterally, no meningismus. All right. Anybody want to talk about that? Bianca, do you want to try? Or Vivian, one of you guys. And if not, I'll just go through it myself.
Hey, can you hear me?
Yeah, I can hear you.
So to me, everything looks normal except the fact that we cannot comprehend like commands for like more detail.
Yeah, and there. So exactly. So everything looks normal. The one thing that I want to point out is that there's no signs of meningismus. Do you know what that means by any chance?
No, I don't. Sorry.
It's okay. So meningismus, there are signs of meningitis. So what we do is we typically will bring up the head, we'll feel the neck, and if we bring up the head and there's inflammation of the meninges, the lining of your brain and your spinal cord, patients will bring their knees up to their chest to kind of decrease that stretch, basically, and then you'll also have stiffness in the neck as well. So one thing that shows is basically he doesn't have signs of meningitis, because one cause of seizure is meningitis or encephalitis. Someone on YouTube is saying temporal lobe language center. Possibly, yeah. If he's having a inability to speak, or he's not comprehending commands, so he's having some processing issues. That might just be because of a seizure too, not necessarily a stroke, but we would keep that in our differential. All right, so he's otherwise awake, opens eyes, oriented only to name, gives confused, incoherent responses to other questions, follows simple commands using all limbs. Okay. Anything else you guys want to point out with that? I think we got everything here. Okay. This is I believe it's the 50-year-old loss of consciousness case. Can you guys hear me okay? Okay. All right. So it's okay. Cool. So we'll move on to the next part. All right. So differential diagnosis. So shortly after initial exam, the patient becomes extremely lethargic. He responds to deep pain by withdrawing, and he is able to protect his airway. He's noted to have the following: heart rate of 30, BP of 74/52, respiratory rate of 10, pulse ox 94, pupils are equal and reactive. At this time, differentials that cannot be excluded. Okay. So does anybody want to interpret the new vitals for us? All right, go first, Neha.
So the heart rate is very low, and then the BP
Yeah.
it dropped a lot, and then the
Yeah.
respiration is also really low, and the pulse oximetry seems normal.
Yeah, it's going towards the lower side. We didn't get the first one, so we don't know if this is a change, but this is weird. So
Yeah, dropped.
okay. So he's unresponsive. He is responding when you, I guess, when they're doing like a sternal rub. He is starting to respond. He's breathing okay. He's protecting his airway, but those vitals look really weird. All right, so withdrawing means more like, so when you do like a sternal rub, he'll kind of withdraw away from you so that he protects himself. Basically, it's if you're rubbing on somebody's sternum, that hurts a lot because you're grinding your knuckles into there. And so a lot of people, if they're with it, they will withdraw from it. But if they're completely unconscious or gonna die, they won't do that. I hope that makes sense. All right. So what are the differentials? So alcohol intoxication. I don't think being acutely intoxicated with alcohol would cause a low heart rate, low blood pressure, low respiratory rate. I mean, will it? I don't think so. What do you guys think? It could be. I mean, honestly, I don't really know. So we can, Yasmin, you said maybe, so I will include it. What about alcohol withdrawal? Oh, that's right. If they took benzos and alcohol, they can be severely depressed. Well, I guess if you drank enough alcohol, then in that point, then it can. So that is a good point, Dr. Manzana. All right. Wouldn't they smell alcohol? Potentially, but we don't know. It's not given here. So, We can't assume that. If you, the question is, wouldn't they smell alcohol if he's acutely intoxicated? So yeah, so we'll include alcohol intoxication. What about withdrawal? Typically, withdrawal, you will see more tachycardia. You'd see more elevated BP. They'd be more agitated. The only reason why I might keep it, because they might have something else going on top of it, but the reason why I would keep it is maybe that's the reason why he's having a seizure. So you can, when you go through withdrawal, you can have delirium tremens that can lead to seizures. So, but there'd have to be something else to explain why his heart rate is so low and his BP is low. But I don't think we could rule out alcohol withdrawal necessarily. All right, what about a cardiac arrhythmia? What do you guys think? Maybe. So if your heart rate is low, potentially an arrhythmia can be causing that, like a heart block or something like that. We don't know what the rhythm is. I think because this is a new acute process. I think what we had on the physical exam doesn't apply to this right now. So the heart rate right now is 30 and has a low blood pressure. So if you have like a heart block, where the signal from the top of the heart isn't really conducting down to the bottom of the heart, you can have something like an arrhythmia causing this bradycardia. So I would include it. I don't know if I'm wrong though. Hypoglycemia. Hypoglycemia. So what do you guys think? If your blood sugar is low, it can cause a seizure for sure. So I would include it for that. But typically, what I would see with hypoglycemia is the heart rate would be more elevated. Patients feel more palpitations than they do not. So, trying to think if it can cause hypotension. I'm not sure about that. Hyperventilation syndrome. So you're just breathing so fast that you're passing out, I guess. Not when his respiratory rate is 10 and before was 20. So he wasn't really hyperventilating. What about an intracerebral hemorrhage? Would you guys include that? So basically a bleed in the brain. I probably would. Yeah, so I would, because that can definitely cause a seizure. And I'm trying to remember the reflex. If you have increased intracranial pressure causing a herniation of the brainstem. Dr. Monsanto, you're going to have to remind me of that. I thought that it caused like hypertension first and then hypotension.
Yeah, so you could get bradycardia. You're going to have decreased respirations. So the triad you're looking for is Cushing's triad. Yeah, and that's exactly correct. So you have Oh, so you go ahead, Dr. Knock. You got it.
Doesn't it cause hypertension first before hypotension? Or is that incorrect?
Honestly, I forgot.
Okay. Also, your baby sounds so cute. All right. Thanks, man. All right. So yeah, I would include that. Meningitis, he didn't really have meningeal signs on exam. He was afebrile. I would probably, I probably wouldn't include it, but I actually no, we can't. They're saying we cannot be excluded based off of history and physical exam. So if we had a high enough suspicion, I think maybe we'd have to do a lumbar puncture to completely exclude it. So possibly. What about an opioid overdose? So you would get a lumbar puncture to see if to test the CSF. Yeah, you would see if there's bacteria, how many white blood cells are in there, all of that. So yeah. Opioid overdose it's a depressant. It can cause low respiratory rate, depending on how much they took. It can cause a low heart rate. So I would include that. Orthostatic hypotension. So basically, that's when you stand up, your blood pressure drops because everything pulls to your legs and your heart can't compensate for it, and so you pass out. What do you guys think? Yes. I probably wouldn't. The reason why is that it looks like this is happening during examination. It's we don't really know if there's positional changes, but you would typically have a more elevated heart rate. Your blood pressure can come down, but you would have if you're pulling everything down, you're not having output, but the heart rate generally would be going up. So I wouldn't include that. Psychiatric disorder, that's some psychiatric issue that's causing him to maybe have like a pseudo seizure. I wouldn't include it because we have enough vital evidence that this is not psychiatric. Pulmonary embolism. Pulmonary embolism, I don't think would cause a seizure. Which let's just add seizure in there. And it would cause more tachycardia than it would bradycardia. Even if your blood pressure is low, your heart's going to want to try to push past that. I probably wouldn't include it unless you guys have a reason why. Yeah. Okay, cool. Stroke. Oh yeah, and his breathing is normal. Duh. Or it's not normal, it's actually low. With a pulmonary embolism, you typically be tachypnic. You'll be breathing faster. So that's a great point. Stroke affecting posterior circulation. So posterior circulation strokes, if I remember right, they will cause more syncopal-like episodes. So yes, I would probably include that. A subarachnoid hemorrhage, that's basically a bleed, but in a different part of the brain. Subarachnoid hemorrhages will cause that thunderclap, headache, severe onset, worst headache of their life. They can pass out. Is it under the meninges? So yeah, so the arachnoid. So you have shoot, I'm gonna forget the different layers. But basically, the subarachnoid hemorrhage is below that, but above your brain. And so what you see is the bleed, if I remember right, within the sulci. But you'll have this severe onset headache, worst headache of their life. It's like a thunderclap, and sometimes patients will lose consciousness and then come back and then seem completely fine, and then they decompensate again. I would include it. And then vasovagal syncope is some response to something. So it's like somebody, let's say, gets a blood draw and they see their blood and they have an overwhelming sympathetic response. So it's like that fight or flight. Your body's being put into fight or flight mode. Then your body, to compensate for that, to calm you down, basically stimulates your vagal system, and that calms everything down. But sometimes it calms it down so much that it slows down your heart rate, and and basically your cardiac output goes down, and so you have decreased perfusion to your brain, and then you pass out. So it's typically because of some stimulus, and so. We don't know what was going on in him right before, or what was happening when he was being examined. I would include it because it's a common cause of loss of consciousness. So let's see. Did we get any wrong? Yeah, we got a few wrong. All right, alcohol intoxication can cause loss of consciousness and confusion. Withdrawal can cause seizure and confusion. Arrhythmia is the most common cause of sudden loss of consciousness in his age group. He was 50, I think, and may manifest as brief seizure-like activity. So when people lose consciousness, a lot of times when we're fainting, we do tend to. A lot of times you'll have like a jerking of the arms and legs, and so that can look like a seizure. I think they were saying he was doing that for a long period of time. So I don't know if that is quite consistent, but it can look like a seizure. Hypoglycemia is considered in everyone with altered consciousness. Hyperventilation syndrome, patient is still symptomatic despite normal ventilation rate. So intracerebral hemorrhage is a rare cause of complete loss of consciousness, but it's too important to ignore. Meningitis, okay. So it should not be considered because the patient is afebrile and has lessening loss of consciousness. No meningismus is noted. So I guess we don't have to get a lumbar puncture, which makes sense. Opioid overdose, the patient never had signs of depressed respirations and his pupils are not constricted. Well, yeah, his pupils aren't constricted, but this looks like depressed respirations to me. I guess it's not, fine. Fine. Okay. Orthostatic hypotension, patient lost consciousness while he was seated. Psychiatric disorders unlikely to cause tongue biting and incontinence. So that makes me think more of a seizure. If a PE had been severe enough to cause loss of consciousness, the patient should have tachycardia and or hypoxia, which we noted. Seizure is suggested by shaking of extremities, drooling, urinary continence, and tongue wound, and transient confusion after the event. So that's what we're talking about, that post-ictal type state. Stroke affecting the posterior circulation is one type of ischemic stroke that commonly causes loss of consciousness. Subarachnoid hemorrhage may cause loss of consciousness, but typically secondary to severe headache. So that's what I was talking about, that thunderclap type headache. It usually does not cause much confusion or focal neurologic findings and often causes meningismus. So I guess they're saying it's less likely, but we can't rule it out. And then vasovagal syncope is the most common cause of transient loss of consciousness and may manifest as brief seizure-like activity. Okay, cool. So which of the following are essential to do immediately? So do you guys want to check the glucose? Yeah, right. BP measurement every 5 minutes until stable. Yes, I think so too. Cardiac monitoring. So yeah, if he's as bradycardic as he is, I definitely would. Cold caloric testing. I actually don't even know what that is. Yeah, I don't know what that is, so I'd have to look it up. What about dextrose, 50 grams IV? So that's basically sugar. Yeah, I guess I would probably hold off until we know. If we do a quick bedside glucose and it's low, obviously we'd give that. But I don't think we necessarily have to give it right away. All right, I'll leave it out. What about intubation? Yeah, I think he's not hypoxic right now. So his respiratory rate's a little on the lower side, but he's not hypoxic. Lumbar puncture. Do you guys want to do that? No, right? There's no sign of infection. Well, I guess if you're considering a bleed, well, no, we need to get a CT scan first. So we'll leave that out. Naloxone? No. I guess they're saying that opiate overdose is probably not likely in this patient. So because of that, I will leave it out. I don't know if a guy came in. Well, he didn't have pinpoint pupils. Okay. All right. Cold caloric testing. Thanks, Carlo. The cold water in the ear to check for nystagmus. If abnormal, can indicate brainstem problem. Okay, that's actually really helpful to know. So you're basically irrigating the inside of the ear with cold water, pretty much. And if it causes nystagmus, which is shifting of the eye really quickly, a lot of times we see that in like vertigo. That I guess it can indicate a brainstem problem. I don't know the exact mechanism of how though, so I'd have to look that up. But yeah, so pulse ox, we'd want to make sure that his O2 sat's not dropping too much, and then tox screen. Yeah, I'd want to test for maybe there's other drugs that he used. Okay, hypoglycemia has to be excluded in altered levels of consciousness. So we want to cycle the BP. We want to make sure that there's no arrhythmias or transient arrhythmias that are causing his symptoms. So the patient is awake. Caloric testing is most useful when the patient is comatose. Okay. Dextrose can be deferred pending the bedside glucose results. That's what we said. Intubation, airway and respirations are normal. Lumbar puncture. So it's not immediate action unless subarachnoid hemorrhage is suspected after neuroimaging is done. Okay. Naloxone. So I guess they're saying the respirations is normal, so that's why we don't need to do naloxone, which is fair. Pulse ox to make sure there's adequate oxygenation, and then although toxicology may ultimately be needed, results will not be available in time to affect immediate management. Okay, but they're asking like what we should do immediately. Okay, fine. I would still get a tox screen. All right. So appropriate testing is done, and it shows normal sinus rhythm, 80s on the cardiac monitor. Pulse ox is 96 in room air. EKG sinus rhythm, no arrhythmia or ischemia, and bedside glucose is 94. Anything abnormal there, guys? Yeah, his glucose is normal. Once we go below like 60s, 70s, that's when I'm like, okay, they're hypoglycemic. Let's give them some glucose. But yeah, this is normal, especially if he hasn't really eaten. That's okay. His pulse ox seems fine too. Yeah, 96 in room air. Yeah, everything looks normal. Cool. All right. Given the previous findings, which of the following are most appropriate to guide diagnosis and treatment? So carotid Dopplers. Do you guys know what that is? Okay. So carotid Dopplers are basically you get an ultrasound probe and you look at the carotid arteries on both sides to see if they're open. A lot of times when we're thinking of a stroke, the carotid arteries being narrow can be a potential cause of the stroke, either because it's so narrow that you're not having blood flow going up, or because you have basically atherosclerosis, and that causes, you can form a clot there that gets shot up to the brain. And so you want to make sure that both of those are patent so it has enough blood flow going up. Does that make sense? Yeah. So if we're thinking of possible stroke, I'd probably want to get it. All right. CBC. Do you want to get a CBC in this patient? Yeah. Nassim, why do you want to get a B? Or actually, you said no for this. So why don't you want to get a CBC in this patient?
I said, for me, when I think of CBC, the first thing I would think of is like checking the white blood cell count. And I think in this patient, we agreed that infection probably wasn't an outcome for him or a diagnosis for him. So that's why I'm thinking like maybe it's not necessary.
Yeah.
I just don't think it's necessary.
What about the other parts of the CBC?
So there's iron, right? So testing for iron, like the hemoglobin levels.
Yeah. Mm-hmm.
And then, do they test for creatinine?
Not on the CBC. The CBC, you're looking at the white blood cell count, the hemoglobin, and hematocrit. Both are a function of your red blood cell levels, and then your platelets are the last one.
So then, would the platelets be like essential? Like looking at the platelets?
The only reason I'm saying maybe is because if we're thinking a seizure and we think a potential bleed, and he had these pinpoint red dots on the legs that might be petechia, I would say yes, I would want to get a CBC. They haven't brought up the petechia again, so I don't know if I'm just reading into it, but I would probably want to get the CBC.
Thank you.
Yeah. Okay. What about ECG or EKG? I thought we didn't get an EKG. We just got the rhythm strip. You guys want to get an EKG? And EKG is basically the electrical monitoring of the heart, but you look at it from different perspectives versus the rhythm strip is just one perspective to see the rhythm of the heart. Yeah, I would probably get it. What about a head CT? Do you guys want to get that? Yeah. And what are we looking for? Okay, good. Kashika told us to rule out a brain bleed. So, Kashika, what would a brain bleed look like on a head CT?
I'm not exactly sure, but I do know that with a head CT, you can determine whether there's a brain bleed or not.
Yeah. So when we look at a non-contrast head CT, what we see is because of the because of the iron in the blood, it tends to look brighter. And so if we see a bright spot on the head CT that's not where we expect a vessel to be, we can say that there's an acute bleed in that area. So yes, I would get a head CT for sure. What about a lumbar puncture? And there's a specific reason why we don't want to get a lumbar puncture right now, because you can use a lumbar puncture to see if you have a bleed. I think it's more in the subarachnoid space, because if you do that and you see blood in there, not because of the insertion, but as you go through and collect more vials, if you see blood there, that can tell us that there is possibly a bleed. But there's a specific reason why we don't get a lumbar puncture right away in patients we suspect to have a brain bleed. And why is that? So would it be dangerous since he might get another seizure? It's not because of a seizure. So if we think of a brain bleed as being a bleed into an enclosed space, it's not going to cause additional bleeding. So our brain is encased in a hard skull, right? And it's an enclosed space with a fixed volume. If you are, yeah, exactly. Avery, do you want to explain?
Can you hear me okay?
Yeah.
Okay. I just know that it's like you have increased pressure within your skull. So, especially with a brain bleed. So due to like the blood that's occupying your brain, I just know that it can compress the brainstem after a sample of cerebrospinal fluid is removed.
Yeah, so the way that I think of it is that there's a specific volume of CSF in the spine that's holding pressure up, and if you're having a brain bleed from up top, that bleeding is occupying space that your brain would normally occupy, and so there's more volume in a fixed volume space, right? There's more things that are trying to come out in that volume. So the only way for your brain to go, it can't go up because that's an enclosed area, is to go down. And so if you remove that volume of CSF at the bottom because you're doing a lumbar puncture, now you create a way for fluid to go out, and so that pressure up top is going to push that brain down, and so you can herniate everything down, and you can cause compression of the brainstem, and that is no bueno. So we don't want to do a lumbar puncture for that specific reason. Okay, so do you guys want to re-examine the patient? Yeah, and that's never a wrong answer. Seek additional history from patient's family and records. What about that? It's never a wrong answer. Yeah, so history of alcohol use, drug use, hypertension, and any other past medical history, definitely. What about a chem panel? That's looking at electrolytes, your glucose, and your BUN and creatinines. Both are functions of your kidneys. I would say yeah, because if you have electrolyte abnormalities, you can have altered levels of consciousness, but typically not. Well, and then also you can have seizures too. So yeah. So tilt table testing. Forget what that's for. I think that's for vertigo. Not vertigo. Is it for vertigo? Dysautonomia? Okay. I'd have to look that up. And then tox screen. Would you guys want to get the tox screen now? Yeah. Okay. Cool. So tilt table test is unnecessary because physical exam for orthostatic hypotension is a better initial screening test than sophisticated testing. So I guess it's looking for dysautonomia. Okay. All right. So carotid Doppler testing, anterior circulation ischemic stroke or TIA is unlikely. Okay. CBC is low yield, but generally recommended to exclude severe anemia, leukemia, thrombocytopenia, thrombocythemia, and thrombocytopenia, any of which can cause compatible findings. Okay. EKG is important to exclude arrhythmias and MIs that can cause syncope. Head CT, new onset seizure, and focal neurologic findings both warrant immediate neuroimaging. Patient had focal neurologic findings. I thought all of his, motor function was intact. Meningitis unlikely because the patient's afebrile, no meningismus, mental status improving. We want to re-examine. We want to get more history. Chem profile, exclude metabolic causes in patients with sudden new onset seizure, and then tox screen. Again, they don't want it. Okay, I guess if there's no signs of potential toxins, then we wouldn't get it. Fine. All right. So, anything on the CBC? Anything that you guys notice here? Didn't they say yes to alcohol intoxication? Yeah. I think they did. So I don't know. So anything on the CBC? Yeah, it seems fine to me. EKG looks normal. Medical history, osteoarthritis, controlled asthma, no hospitalizations, tonsillectomy, albuterol is needed, meds look okay, no allergies, no family history. He drinks socially, no recreational drug use, no cigarette smoking or tobacco use, no travel, employed attorney, married with children. So on re-exam, he's now awake, alert, and complaining of only a mild headache. Temp is 37. Neurologic exam shows normal gait, balance, and motor function, but with subtle dysdiadokinesia in the left upper extremity. Monitor has continued to show normal sinus rhythm in the 80s. Stressful life as an attorney, possibly. Possibly, yeah. I mean, that makes sense to me. All right. Anybody want to discuss the physical exam? What's dysdiadokinesia? Does anybody know? So basically, what that is when you're looking at, I guess, coordination, we ask you to do typically a rapid alternating movement. So you do this back and forth, and as you do that, if you have it, if you're unable to do that, if you're not smooth and symmetric, then that tells us that there's a coordination problem, possibly in the cerebellum, which is your coordination function area. So does that make sense? Okay, cool. Everything else looks okay, other than that. Okay, let's move on. All right, head CT. Who wants to read that head CT? All right, go for it, Nassim.
Okay, so I'm if I'm not wrong, I think that all of like that white area surrounding the brain should not be there.
Are you talking about this right here?
Yeah, like the white surrounding like white
that's
border.
That's just bone.
Bone? Okay.
Yeah, that's
Okay, never mind.
It's the window that you use. So this is more looking at the brain itself. So you're focusing on that. So that's why the outside looks so bright and white. But yeah. All right. What else?
Okay, I think that on maybe towards like the cerebellum or like the occipital lobe area, like towards the back. I don't know. I think I see like a white spot.
Talking about this right here?
I don't know if that's normal or not, but
yeah, I don't think so. I don't think so. This white spot right here does not look quite normal to me. And remember, what I tell you guys is if you're not sure on a read of a scan, generally in our bodies, we are symmetric. So whatever's happening on the left side, for the most part, it should be happening on the right side. This right side right here, this little spot, I mean, maybe right there, but it doesn't look the same. And so I agree. I think that this is something that's not supposed to be there. And what I typically would like to do also is make sure that there is no shift of the brain. So if there's a bunch of stuff going on this left side and it's shifting everything on the right side, shifting everything to the left, you would see this middle portion right here, this line coming down, shifted over. And it doesn't quite look like that. I think it looks okay. Anything else that you're seeing that's abnormal?
I feel like the right or the left side of the brain, I feel like it's kind of I don't know how to describe it, but it's like where there's kind of like less like brain tissue than compared to the right side, where it kind of looks like it's like he's lost some brain tissue. If that
Yeah,
makes
like
sense.
he kind of lost some volume. I mean,
Yeah.
possibly. I know what you're saying. Like, there's more like dark spaces in here than there are on this side. It's possible that it might just be a different kind of cut almost. So if it's not exactly like a straight cut across, and if it's more angled this way, you might be seeing a little bit more of the upper part of that left side than you would be on the right. So that's one possibility. I would probably want to scan up and down and see if that's consistent throughout. But yeah, that's something that you'd want to keep an eye on. I don't know if we would be able to say that from just this still image, though. Patrick's asking, can you determine about the ventricles from here? I don't see the ventricles. The ventricles typically would be like about right here. I think this is higher up on the brain slice, so you can't really comment on the ventricles from here. Dilated right lateral ventricle. Okay, so patient is sent for CT, and what's the correct interpretation? So dilated right ventricle, like we said, we can't really see. Intraparenchymal hemorrhage on the right parietal area. So is that what we're calling this right here? Yeah, probably. So intraparenchymal just means that it's within the brain area. So he has a hemorrhage within the brain area right there, I guess is what they're saying. Ischemic stroke on the right parietal area. Ischemic strokes won't, on a CT without contrast, won't show up like this, so it wouldn't be an ischemic stroke. Basically, that part, an ischemic stroke meaning that part of the brain lost blood flow and it's actively dying, or has died already. You typically won't see that right away on a head CT without contrast. And then cerebral edema, probably not. I honestly don't quite know exactly how I would read cerebral edema on a head CT because I don't see it as often. But I would go with intraparenchymal hemorrhage. Does everybody agree with that? Yeah. They agreed too. Okay. So he has some type of bleed. So at this time, likely differentials can include which of the following. Alcohol withdrawal wouldn't really cause a brain bleed, right? Yeah, right. So cardiac arrhythmia. I mean, his EKG was normal. The rhythm strip has been normal. I probably wouldn't include it. Well, he was bradycardic, actually, at one point. I don't know if that's technically cardiac. I don't know. Do you guys want to include it or no? All right, we'll leave it out. Intracerebral hemorrhage. Yeah. Yeah. Seizure. Yeah, probably, right? All right, subarachnoid hemorrhage. So probably not, because the area where the blood possibly is not indicative of a subarachnoid hemorrhage. And I'll show you guys after the case what a subarachnoid hemorrhage looks like, so you can kind of see. So just remind me of that. Thrombocytopenia. Did they ever give us his platelet count? Because I don't remember seeing a platelet count. So I guess yes, it's still in the differential. Or no, or yeah. Well, if you have low platelets, that can be a reason why you're bleeding. Because we also don't know why this guy is bleeding into his brain, right? Okay. And then vasovagal syncope. I mean, that's not going to cause a brain bleed unless he hit his head, but he had no signs of head trauma on exam. I don't know. I'd probably leave it out. Okay, cool. So no history of alcohol use. Mental status usually normalizes quickly when cardiac rhythm normalizes. Patient had prolonged period of confusion despite normal rhythm, so not likely cardiac. Intracerebral hemorrhage. So the CT scan shows a hemorrhagic lesion. The seizure should be included based on the patient's history and test results. Subarachnoid hemorrhage, CT does not show blood visible around the sulci. So, and I'll show you guys that. Thrombocytopenia should be considered because the patient has a platelet count of 3,000, which is extremely low. They didn't give us that, right? Like I didn't just miss something somewhere. Okay. Okay. Yeah, I don't think so either. So vasovagal, neurologic exam and neuroimaging detect abnormalities in the patient, so it's not going to be vasovagal. All right. So the next, okay, so before we go on, So I guess this patient now has a platelet count of 3,000. So why? And I guess this is what this part of the case is getting at. So why does this patient have a low platelet count? Because the platelet count might actually explain why he has the brain bleed and why he had the seizure. I think someone on TikTok is saying can cause brain bleeds and low platelets. So they're saying maybe TTP, which although TTP, he doesn't really have purpura. So I don't think so. He has petechiae, but not purpura. So it could be a tear in the red blood cell in I guess the vessels. Is he taking any medications that might affect his platelet count? Not really, because he's only taking aspirin, if I remember right. And aspirin decreases the platelet, how the platelets work, but doesn't really decrease platelet count. So, which we would want to stop that aspirin to preserve the function that the platelets have in general. All right. So what are some of the reasons why? And I guess we can go through this and it'll kind of help us determine. So no additional testing is needed, proceed to treatment. We got to obviously test this patient, see why their platelets are low. So bleeding time test. So that is basically traditionally what it used to be is you perform some lesion and you test to see how long they bleed. I think you can, I think there's other lab ways of doing it now, which I'm not 100% familiar with, but I don't see it done as often. So I wouldn't include that. What about a bone marrow biopsy? Why would we want to get a bone marrow biopsy in this patient? And anybody can generally speak up. Why would or wouldn't we? Yeah, so Nassim is saying if to see if he's making enough red blood cells. Although the red blood cells probably are not the issue right now, it's probably the platelets. So to see why it is that his platelets are so low. So is there something, so like the megakaryocytes within the bone marrow, is that low? Is there no precursor cells that are generating these platelets and that's why? Is it more of a peripheral problem within his blood itself that it's being consumed? So like if you have something like DIC, which is disseminated intravascular coagulation or coagulopathy, where all of your platelets are being consumed because they're forming little clots throughout your bloodstream. That's one possibility. But the bone marrow biopsy would help us determine if it's something inside the bone marrow that's causing it or outside the bone marrow that's causing the low platelet count. I would say no for this because, and it can be cancer related, yes. But I wouldn't do it right now because there's other tests we can do before we do the bone marrow biopsy. Eventually, this patient might need it, but probably not yet. And then the other thing with the cancer, if this was cancer related, we typically don't see an isolated thrombocytopenia or low platelets that would be something cancerous. We would typically see, because it's not, or at least to my knowledge, it's not very common to have an isolated platelet cell line cancer. A lot of times it's you're crowding out the rest of your bone marrow because you have a different type of leukemia where you're having abnormal white blood cell counts, and so you're not having platelets come out because of that. So, yeah, but long story short, I probably wouldn't get a bone marrow biopsy right at this point. What about a Coombs test? And a Coombs test, because RBCs are normal. Yeah. But I think a Coombs test would tell us if they're, well, actually, you're right, because RBCs are normal, so you probably wouldn't. I'm trying to think if there is, yeah, probably not. What about hepatitis testing? So, okay, so for those that don't know what a Coombs test is, basically Coombs is looking at what are they called? Antibodies against your RBCs. So if you're having lysis or you're having disruption of the red blood cells, the Coombs test will help us determine, is there a antibody is there some type of immunologic reason why we're having this breakage of red blood cells? And what Patrick is saying is we don't have evidence of hemolysis, and the red blood cells are normal, so probably not. This is now a lot of hematology, which I'm very not good at. So, hepatitis testing. What about hepatitis testing? So yeah, I would say yes, actually, because if you have impaired liver function, I don't think we have a liver function test. It can cause a low platelet count, so I would include that. HIV testing can also cause low platelets, so I would include that as well. Liver function tests, like we just talked about, I would include because it can cause low platelets. So your liver is integral in that process. Plasma fibrinogen and D-dimer levels. So fibrinogen, do you guys know what that is for? Fibrinogen and D-dimer. So they're both they're both involved in clotting. And so if you have a low platelet count because you're being consumed from a process like DIC, where you're having little clots form throughout the body, you would want to get a fibrinogen level for that. Because, and I'm forgetting the pathway right now, I believe it is part of the pathway of, shoot, I'm forgetting it now. I'd have to look it up again, but I would probably get it if we're thinking some type of consumptive process for the platelets, but I might be wrong. I told you hematology is not my forte. Peripheral blood smear. Would you guys want to get that? So what is a peripheral blood smear? So you're getting a sample of blood. So you get a sample of blood from the peripheries, from the body, and you're smearing it onto a microscope slide, and you're looking at it directly to see how the platelets look, how the white blood cells look, how the RBCs look, and see if there's any abnormalities there. So yes or no? You guys want to get that? Yeah, me too. PT, PTT. So these labs are helpful in determining any issues with coagulation. So do you guys want to get that? Yes. And then physical exam for signs of bleeding. It's never a wrong answer to do another physical exam. The one I wasn't sure about. Okay, so fibrinogen and D-dimer detect activation of the coagulation cascade and are unnecessary unless coagulopathy or excess clotting is present. Okay. Okay. And I probably just have to go and review this, but I was thinking if you're having something like a DIC where you're just clotting like crazy everywhere, you might want to see the fibrinogen more so than the D-dimer. Yeah, okay. At least Carlo thinks that is agreeable. It's reasonable. Okay, so that's good. All right. So bleeding time test is not sensitive or specific for bleeding tendency. Bone marrow biopsy, unnecessary without reason to suspect bone marrow failure, which we don't right now. Coombs evaluates hemolytic anemia, not thrombocytopenia, which I had to refresh my memory on. Hep C can cause thrombocytopenia, and HIV testing can cause that as well. A lot of viruses can cause thrombocytopenia, and a lot of viruses in general, not necessarily just hepatitis, HIV. Epstein-Barr virus can cause liver abnormalities and low platelets as well. And infections in general can lower your body's ability to push out blood, these different cell lines. All right, LFTs can hepatic dysfunction can cause coagulopathy, and if caused by Hep C, can also cause thrombocytopenia. Peripheral smear determines whether other foreign elements of blood are present normally. So that's looking at the white blood cells as well as the red blood cells. PT-PTT can identify coagulopathy as a contributing cause of bleeding, and then thrombocytopenia can cause occult bleeding in the GI tract. Can cause so you're looking for any signs of GI bleed. I was also honestly thinking more of like, is there any other signs of petechiae or even purpura? Because one like thrombotic thrombocytopenic purpura would be on my differential as well, although there's some other signs that patient might not necessarily have. Okay, so hepatitis is normal, HIV is normal, LFTs are normal, peripheral smears, thrombocytopenia, otherwise normal, PT-PTT is normal. So repeat exam shows petechiae present on both lower legs and an area of ecchymosis on the upper back. Stool's negative for occult blood. Spleen is not palpably enlarged. So the spleen can be one of the reasons why you have a low platelet count, because it basically eats up all the can eat up all the platelets. It can sequester them. So he has a big bruise on the upper back. Maybe he fell on that, and then he has petechiae, these little red dots on both lower legs. So, okay. So testing for the reason why he has these low platelets are pretty much negative. All right, so what's the most likely diagnosis? So would we call this bone marrow failure? No, right? Because all the other cell lines are typically fine, right? The red blood cells are fine, and the white blood cell count was normal too. And so if we're calling it bone marrow failure, we'd probably see a low count for all three of those. Okay. Drug effects. Is the patient on any other drugs? I think it was only aspirin, right? Yeah, so aspirin wouldn't typically cause a low platelet count like this. Immune thrombocytopenia. Yeah, so is there a autoimmune type process that is causing the platelets to be consumed, basically, or be destroyed? So yeah, I would agree with that. I thought, yeah, okay. So what about sepsis? And I know this is like the most likely. So no, it has no signs of infection. And then von Willebrand disease. Probably not. And I sorry, I just looked it up right now. ITP, I always thought as idiopathic thrombocytopenia, and it's the same name. And the reason why I was looking at it is because idiopathic basically means we don't quite know why he has this low platelet. So von Willebrand's is and I looked it up to make sure that I get the right pathway. So it binds to factor 7 and is a key component in clotting. And so if they have a clotting protein and platelets in blood vessel walls, which help form a platelet plug during the clotting process. So in von Willebrand's disease, you have a missing or defective von Willebrand's factor. So you're not able to clot as well. So yeah, so I think you'd be more likely to bleed. I don't think it would cause a low platelet count like this. Okay. So bone marrow failure would affect other blood cell lines. Drug effects, nothing he's on would cause this. No signs of infection for sepsis, and von Willebrand's are platelets are typically dysfunctional in patients with von Willebrand's disease, but the patient count is normal. So I guess what they're trying to say is the platelets are dysfunctional, but they're present. But for this patient, they are low, so it's probably not von Willebrand's. And then, so there's no other likely explanation for the patient's condition. So so we would say it's more ITP, so idiopathic or immune thrombocytopenia. Okay. Yeah. Okay. So someone on TikTok is saying von Willebrand's can cause brain bleeds. Yes. So at this time, which of the following are part of the most important management? So are we going to admit this patient to the hospital? I actually would. He has a brain bleed, right? So he has a brain bleed, and he has really, really, really low platelets, right? So I would. What about alteplase? Do you want to give this guy alteplase? First of all, what is alteplase? It's TPA, so it's a clot buster. So if this guy is bleeding, it can treat an MI if you can't get them to a cath lab on time. You can use TPA, but so that it's more used for like ischemic type strokes to break up the clot that's in the brain. So we don't want to give this guy something that's going to make him bleed more, right? So no. What about fresh frozen plasma? Yeah, I wouldn't. So fresh frozen plasma provides a lot of the clotting factors needed to form clots. It doesn't do anything really to help with the platelets. So I don't think fresh frozen plasma would be helpful. What about immune globulin? And what is this, if anybody knows? And it's in the name. Yeah, Patrick, what is it?
Yeah, so it's like almost because immunoglobulins are antibodies, so I guess you're adding in antibodies to help out with the condition.
So why would that be helpful? Do you know?
I guess I'm not so sure, but maybe it can start an immune response and maybe do an uptick of maybe like some blood cell counts, like platelets maybe.
So I think what this is, what they're saying by immune globulins is IVIG. So it's intravenous immunoglobulins, and what that is like a pooled cell, I guess, cohort of different types of immunoglobulins that will basically decrease any autoimmune process that's going on in your body. And the way that I remembered it, which might be wrong, and I have to go back and look it up, is that you're basically adding adding these other immunoglobulins in there that will help mask up the ones that are dysfunctional and causing the dysfunction in your body. And so I don't know exactly how, like, what it attaches to, but that's the way that I remember it. And so if with any autoimmune process going on, you can use IVIG to help decrease that immune response. So I would say yes. Ativan or lorazepam. Do you guys want to give that? Maybe, but he's not really having a seizure right now, so probably not. Okay, so somebody wrote IVIG distracts the body from attacking your own immunoglobulins. Yeah, I agree with that. I think that but I think it's more that it's stopping that response from happening. So I think the patient is not actively having a seizure right now, so we wouldn't need to give Ativan. And then phenytoin is also a anti-epileptic. So we can give it, but this patient, I don't think has a history of seizures. And if this was a one-time seizure or like one episode of seizures, you don't necessarily have to start it. I know in our hospital, it's kind of hit or miss. If we think that a patient might have recurrent seizures, we would start something like Keppra, but I wouldn't start phenytoin unless he has probably another seizure. What about a platelet transfusion? You guys want to do that? Yeah, I agree. What about steroids or prednisone? I probably would want to give steroids because steroids are an immunosuppressant, and so they will decrease that immune response. So if your immune system itself is causing the decrease in platelets because it's attacking your platelets, it'll help calm that down. So yes, I would definitely do that. Prothrombin complex concentrate, I have no idea what that is. So if any of you guys know, that would be helpful, but I don't think that is what we would give, but I have no idea. And then a splenectomy. Do we want, it helps clot blood. Thrombin promotes fibrinogen production. Okay. So the patient doesn't really have a clotting problem. He has a platelet problem. So I'm going to leave it out. And then a splenectomy. Do we want to take out this guy's spleen? No, probably not, especially when his platelets are low like this. And we don't have evidence that the spleen is large or causing it or being or eating up the platelets. All right. So we would want to admit the patient in the hospital. Alteplase, increase the risk of bleed. FFP, fresh frozen plasma, is not appropriate for managing patients with thrombocytopenia because it doesn't have platelets. It just has those factors to help clot to help clot off. Someone's asking, can prednisone cause decreases in white blood cell counts? Which yes, it can cause a white blood cell count decrease. But our problem right here is not with the white blood cells, it's with the platelets. And we think that there is an immune process going on that's eating up the platelets, and that's why we would want to give prednisone. All right. So immune globulin increases platelet count in ITP more quickly than corticosteroids. So that's why we'd want to give IVIG. Ativan is not indicated for patients who have had a single seizure that has since resolved. Phenytoin not indicated for a single seizure, like we talked about. Although platelet transfusion is usually unnecessary in patients with ITP, it may help patients with severe life-threatening bleeding and with severe thrombocytopenia, which this patient has. So the patient has a platelet count of 3,000. So that's severe enough that we'd want to give platelets. Plus, he has a brain bleed, and so we want to clot that off if we can. So yeah, we definitely want to give him platelets. Prednisone is the most useful initial treatment for ITP. Prothrombin complex concentrate is used for treatment of certain coagulopathies, non-thrombocytopenia, and splenectomy is not done when patients have ITP unless initial drug treatment is unsuccessful. Yeah, and also your spleen will basically tag those platelets that have been tagged with antibodies and eat those up. And if I remember right, that's one of the reasons why spleens can get pretty enlarged or can contribute to the process of having low platelets. Okay. I think we're almost done, guys. So, which of the following features, if present, would suggest a dangerous cause of syncope? Okay. So, associated heart murmur, would that be a dangerous cause of syncope? I think yes. So when we think of syncope, we're talking about a patient loses consciousness and basically falls down and faints. So a heart murmur would indicate that there is a valve that is not functioning the way it should, and so you can't get the blood up to where it's supposed to be. And so because of that, you can have a heart. That heart murmur can indicate a stenotic valve, like an aortic valve stenosis, where you can't get the blood out, and that would indicate, especially if he's having a lot of syncopal episodes, probably a replacement of that aortic valve. So I would say yes. Syncope on exertion. So you're doing something and you faint. Is that a dangerous cause of syncope? I would probably say yeah, especially if we're thinking, and we can think of something like either aortic valve stenosis or even a heart attack if it's severe enough. Onset of syncope during emotional display, that's like vasovagal syncope, where you have that sympathetic response first, and then your parasympathetics come in and try to calm you down, but it's an exaggeration. That's typically not a dangerous issue. You just so I would probably say no for that. Syncope immediately after standing up, that's your orthostatic hypotension, where you're standing up, your blood pulls down to your feet, so you have less cardiac return to the heart, and so your body would try to compensate by pumping faster. So and you probably have felt it where you feel dizzy when you're standing up too quickly, but it's not a dangerous cause of syncope. And the way that I determine if it's dangerous or not is if there is something that compromises your heart's ability to pump blood out. So that aortic stenosis is one of them. Or if you have, that's probably the one big one. Or if like you have something like a stroke, if you're having like neurologic symptoms as well. But that would have to be a pretty massive stroke to cause syncope. Multiple recurrences of syncope within a short amount of time. So yeah, if it's happening a ton, you want to make sure that there's nothing. Yeah. And then syncope preceded by diaphoresis. So you're sweating and then you faint. I think if you, even with vasovagal syncope, you sweat and faint. So I don't think that's specific enough. Okay, yeah. So it was those three. Okay. Which of the following drugs are more often associated with development of thrombocytopenia? I have no idea. Tylenol. Does Tylenol cause thrombocytopenia? So low platelet count. And I'll probably need you guys to help me out with this. I don't think so. Yeah, I don't think so. So we'll say no. Aspirin. Aspirin causes a dysfunction of platelet, how the platelet works, but it doesn't necessarily cause a low platelet count. So I would say no for that one too. Bilirubin, which is one of the type of anticoagulants, I don't think it causes platelet dysfunction either. It works, I think it works more on the clotting cascade. So I don't think so either. Clopidogrel is like aspirin, it's Plavix, but it's like aspirin in that it affects the way the platelets work. It doesn't decrease platelet count. So I would say no to that one. What about heparin? Do you guys know what heparin is? So heparin is an anticoagulant also. It's a blood thinner, exactly. And so it also works on the clotting cascade. So it doesn't directly cause a decrease in platelets. So but there is something that heparin does that can decrease your platelet count. And Patrick's saying, doesn't Tylenol affect liver function, which may cause ITP? I think you'd have to have like fulminant hepatitis, so you have to have like liver failure for it to cause platelet dysfunction. I don't think liver function itself will cause ITP. So ITP, basically we're saying that it's idiopathic. We don't know what's causing it, and so if we know it's because of liver dysfunction, then we can't say it's ITP. But so I don't think it causes low platelets, but yeah, I don't think so. So heparin can cause something called heparin-induced thrombocytopenia. It's a reaction that happens, and that's why when we start heparin, we always want to make sure that the platelet levels are okay. Because if we see the platelets dropping off, we think that I think it's an immune mediated response that causes the platelets to drop like that. So heparin is one of the ones that causes thrombocytopenia. Quinine, I have no idea if it does or it doesn't. Does anybody know? Yeah. It's a medication that treats malaria. I think it does other stuff too. But so yes, I'll say yes because Avery says yes. What about ranitidine? It's also found in tonic water too. Yeah. What about ranitidine? So that's one of your H2 blockers, your histamine blockers. I have no idea if it causes thrombocytopenia. So I leave it up to you guys, yes or no. I don't think so, because I have a lot of patients that use ranitidine, and I can't think of a reason why. So I'll say no. What about trimethoprim sulfamethoxazole? It's Bactrim. It's an antibiotic. I think that one does. And then warfarin is an anticoagulant. It works on the clotting cascade. It doesn't work on the platelets itself, so I'll say no. And we got, wait, what? So Tylenol is commonly associated with thrombocytopenia. I don't know why, but I guess it is. So aspirin doesn't, bilirubin doesn't, clopidogrel doesn't. Heparin does, and that's what we're talking about with HIT. Quinine does, I guess. So Avery, you were right. Ranitidine does as well, which I didn't know. Bactrim, I know, does. Trimethoprim sulfamethoxazole, it's a common reaction, or it's one that we commonly learn about, and then warfarin doesn't. Okay, and then which of the following infections are associated with thrombocytopenia? So I think we talked about EBV a bit ago. So that one does. That's Epstein-Barr virus. That's one of the causes of infectious mononucleosis. Epstein-Barr virus and cytomegalovirus are two viruses that can cause a lot of weird symptoms, and they both cause infectious mono. They both can affect the liver, and they both can cause a low platelet count. So, yeah, that's one of them. What about Helicobacter pylori or H. pylori? What do you guys think? That's a bacteria that's found in the stomach that can cause peptic ulcers. I don't know, is my answer. I'm going to say no. Unless I knows otherwise. Okay. Hep C, we talked about it can cause liver dysfunction and it can cause thrombocytopenia. HIV was another one that can cause a low platelet count. What about Lyme disease? So that's the disease caused by tick bites from Borrelia burgdorferi or something like that. Usually causes like target lesions on the skin. It's like this typical rash that you see. I don't think it causes thrombocytopenia. So yeah, I'll say no. What about syphilis? I don't think syphilis or trichinosis does either. We'll just leave it like that. Okay, so we got everything right except I guess H. pylori causes low platelet count. Cool. Okay, and we'll just do this one super quick. So which of the following types of stroke is least likely to cause loss of consciousness? Anterior circulation, ischemic stroke. Those are the ones that will typically cause like a weakness in one arm or one leg or something like that. I think they were saying before that it doesn't, and typically it won't unless it's a really big stroke, so I will leave that out. Embolic type strokes can cause loss of consciousness. So an embolic stroke is you have a clot from somewhere in the body that gets shot off to somewhere else in the body. In this case, it's to the brain. And so if you have a large clot that blocks off your circulation, that's generally a bigger type stroke. And so it can cause, I think it can cause loss of consciousness. Posterior circulation stroke, I believe does as well. You can only choose one. Or least likely to cause loss of consciousness. So I think the posterior circulation stroke can as well. And then the subarachnoid hemorrhage, I don't think so. Damn it. I'm going to say it's anterior. So anterior circulation strokes affects only one cerebral hemisphere, does not significantly impair consciousness. Okay. All right, and we're done with it. So ITP is a bleeding disorder caused by thrombocytopenia, not associated with a systemic disease. Typically, it is chronic in adults, but it is usually acute and self-limited in children. Spleen size is normal in the absence of other underlying conditions. Diagnosis requires that other disorders can be excluded, though through selective tests. Treatment includes corticosteroids, splenectomy, immunosuppressants, and thrombopoietin receptor agonist drugs. So those are drugs that help produce platelets. For life-threatening bleeding, platelet transfusions, IV steroids, IV anti-D immune globulin, or IV immune globulin, IVIG, may be used individually or in combination. Cool. All right, any questions about that case? I know for me, that was a lot harder than I anticipated. Also, they didn't give us all the information, so I blame the platelet count, I don't think. So, yeah, any questions about anything, guys? Was this helpful? I know for the people that were in the classes, we haven't really talked about stroke. We haven't really talked about hematology, like ITP or other issues with the blood. So I don't know if this was like way over your head or you were able to kind of keep up with it. But that would be helpful to know. So that way either I'll teach more about stuff and I'll probably have to prepare more for some of these cases to guide you through them. Or if this was okay and you were able to follow along, then maybe we can continue this format. So what was the reasoning for his dysdiadokinesia? I think it's probably the area of his stroke, maybe. That's why, because it was, I don't remember what side it was on. But that's the only reason why I think he might have had maybe that's why they were saying he had a focal neurologic deficit, because he was having that inability to do that. So the rapid alternating movements on that one side. So I think that's why. So what do you guys prefer? Do you prefer we stick to cases that you've learned about, meaning like I will teach stuff ahead of time and we'll get a case on cards or on abdominal pain, or even do some neurology, but I'll put some videos out for neurology. What do you prefer? And while you guys decide, this is what petechiae look like. So it's these little pinpoint lesions on the face. It kind of looks like that. On the legs, it can look like that. Although this is probably not really. This looks like, I don't know if this is petechiae. They're more pinpoint type. No, this doesn't really look like petechiae either. This is more like it. So these little pinpoint red lesions on the skin. And then I guess purpura, I typically think a little bit more purple. But they're saying that this petechiae is purpura. I don't know if I would completely understand this. Okay. So you guys let me know. I will let you guys think about it, and then either send me feedback on Instagram, Facebook, TikTok. It doesn't really matter. And then I'll continue doing this while we prepare for the next session of rounds. Okay, so a mix of both. All right, so I'll do that then. And then I don't know if there's anything else that I'm forgetting to look up to show you guys. Oh, subarachnoid hemorrhage. So this right here, I don't know. Okay, so this right here is an intraventral. This is where subarachnoid hemorrhage is this right here. Intracerebral hemorrhage is more in the parenchyma. And if we look at a CT scan, you're having white spots within the sulci of the brain. Not so much in the parenchyma of the brain. Okay, a mix of both is what most people are saying. All right, so I'll work on that. I'll do a mix of both. I appreciate everybody's time, and I hope you guys learned something. I definitely did. So, and I will see you guys later. Let me know if you have any more questions. All right, thanks, guys.